I will talk today about coronary physiologic lesion assessment using FFR and IFR. I will explain the concepts, the technical tips, the discrepancies between those two indices, as well as many applications in several settings, such as ostial guide ventricularization, which is quite common, serial stenosis, left main, aortic stenosis, MI, pre-CABG, and post-stenting. I will start with the concept. So in a simplistic way, let's imagine this is a stenosis here, and this is pressure in the aorta. This is a pressure distal to the stenosis. And this is the microvascular coronary circulation. In a simplistic way, FFR compares pressure distal to a stenosis to pressure in the aorta under maximal hyperemia using a coronary wire that has a pressure sensor. However, FFR actually aims to compare the peak myocardial flow past the stenosis to the theoretical peak myocardial flow here had there not been a stenosis, in which case distal pressure PD equal to PA. So FFR is really a flow ratio. Even though we're using pressures, we're trying to guess what is the flow ratio at peak myocardial flow. Flow ratio in the presence of a stenosis to the theoretical flow in the absence of a stenosis. Now, since myocardial flow equal microvascular flow and is equal to pressure divided by microvascular resistance, to make those pressure in those two settings, stenosis and no stenosis, to make those two pressures correlate with flow, you have to annihilate those microvascular resistance. Okay, you eliminate those microvascular resistance, flow and pressures start to correlate linearly. That's why we give intravenous adenosine to eliminate that microvascular resistance and to make flow and pressure correlate linearly, at which point PD divided by PA becomes a ratio of a flow D divided by flow A, okay? Another important thing is that in the process of doing so, adenosine dilates the microcirculation and therefore increases myocardial flow and mimics exercise. So adenosine achieves two things. One, it annihilates the microvascular resistance and makes flow and pressure correlate. Two, it's mimicking the flow rise that you see with exercise and the effect of the lesion on that flow rise that would occur during exercise and the flow limitation of that lesion during exercise. Now, more interestingly, and to better understand the behavior of that PD-PA ratio, I like to apply that same equation here, not just at the level of the microvascular resistance. I like to apply it at the level of the epicardial stenosis resistance. And that will allow you to understand the behavior of that PD-PA ratio in various settings. So PA minus PD equal flow by resistance across the stenosis. If flow increases, you get more relative drop in pressure past the stenosis. So the difference between PA and PD will rise if the flow rises, and PD will relatively drop more if you increase the flow. And that's what happens with adenosine. With adenosine, flow A rises, which causes a drop in pressure PD, and that drop in pressure PD corresponds to a drop in flow past the stenosis at maximal hyperemia. And that's kind of what adenosine is trying to achieve, and that's how you understand that when we give adenosine, you get a dramatic drop in PD pressure compared to the drop in pressure at rest. Furthermore, that drop in pressure corresponds to a flow drop. So another application of that equation, so one, it allows you to understand the behavior of PD-PA with adenosine and with exercise as you increase the flow. Another thing, it allows you to understand the behavior in various arteries. So let's say you have a larger territory. The larger your territory, for example, you have an ostial left main, the larger your territory, the higher the flow at rest, and especially with hyperemia and adenosine. Therefore, the higher the flow, the more you get a drop in pressure and a drop in flow past the stenosis. Okay? So for the same stenosis severity, let's say 80%, a proximal LAD or a left main stenosis is far more likely to be significant hemodynamically than a small diagonal stenosis. Again, more flow, more myocardial territory, more drop in pressure and more drop in flow across the stenosis for the same severity of anatomic stenosis. Also, for the same stenosis severity, the length increases the significance of stenosis because resistance here across the stenosis is interpreted by the Poiseuille law. So resistance is very much dependent on the radius, but it also depends to some degree on the length of the stenosis. So that's why the longer the stenosis, the more likely you are to be significant. So what we call significant FFR, fractional flow reserve, is an FFR of less than or equal to 0.80, meaning you're getting more than 20% drop in flow across the stenosis under maximal hyperemia. This identifies ischemia with a very high specificity, and the specificity is 100% if that FFR is less than 0.75. Now, those are two illustrations of FFR. And you see here the PA in red, the aortic pressure, and the PD distal to the stenosis in green. The ratio of the means of those pressures under adenosine is FFR, which is low in those two cases. Now, very importantly, when FFR is less than 0.80, the distal green pressure, coronary pressure, becomes ventricularized and loses its dicrotic notch. So you have to always look for that change in morphology, not just the ratio of numbers. And why does this happen? Blood flows in the left coronary predominantly during diastole. You have higher diastolic flow than systolic flow in the coronaries, particularly the left coronary flow. So since flow is highest in diastole, again, based on that equation, whenever you have higher flow, you get more drop in pressure. So since flow is highest in diastole, you get more drop in pressure in diastole, more pronounced drop in pressure in that early to mid diastole, and that's what creates that ventricularization of the pressure waveform. It's very important to have this, so much so that let's say you're calculating your FFR and you get this, and the machine tells you the FFR is 0.70, but this is the morphology of PA and PD. There is no distal pressure ventricularization. This tells you there is an error. This is not a true FFR. What happens here is that there is an error in zeroing of the two pressure transducer, meaning the pressure transducer of the FFR wire and the pressure transducer of the aortic pressure are not calibrated and zeroed at the same level. Basically, what you need to do, you need to pull back that pressure wire, make those transducers at the same level at the tip of the guide, and make sure they read the same pressure. Make sure those two pressures are equalized. Most likely in this case, those two pressures are not equalized. You have unequal levels of those two transducers, creating a fake difference in the pressures. This is actually a very common error that happens in up to 20% of FFR measurement. You might have equalized the two transducers properly at the tip of the guide, but you might have got what we call transducer drift during your case, meaning that pressure sensor has changed its zero level and calibration as time went by. So you need to pull back and re-equalize at the guide tip. This is an illustration of a case to illustrate another concept related to that. This is a patient with a mid-LAD stenosis here, moderate stenosis, around 50%. Importantly, that LAD is supplying large collaterals to the occluded, chronic totally occluded right coronary artery. So if you assess FFR of this LAD, and let's say it measures 0.75, what do you expect the FFR of this LAD to become or to be if you fix that RCA stenosis and if that LAD is no longer supplying collaterals to the RCA. That's a very important, actually, interventional board question. It's important to know that when you have an RCA CTO and the LAD is feeding it, the LAD is providing collaterals, and therefore the LAD is providing a much larger territory, is providing double territory than if you did not have an RCA CTO. Therefore, because it's providing a larger territory, it's having higher flow. Therefore, the drop in pressure and the drop in flow past that stenosis is more dramatic. Therefore, the FFR is more extreme in the presence of collaterals than if you did not have collaterals. Meaning that FFR that's 0.75 now, if you did not have CTO of the RCA, or if you fix the CTO of the RCA, that FFR will become 0.83. And studies have shown that FFR of the parent vessel, LAD in this case, rises by 0.05 to 0.1 after fixing CTO of a dependent vessel such as the RCA. And that's important in decision making. If you have this anatomy and you're planning on fixing the RCA CTO, it's amenable to PCI, then do not assess the FFR of the LAD before fixing the RCA. It will be exaggerated. Fix the RCA, then assess FFR of the LAD, and fix the LAD if needed. On the other hand, if you have no plan on fixing that RCA CTO, it's way too complex to fix it, then FFR will represent whether this LAD lesion providing double territory is hemodynamically significant, and whether fixing that LAD stenosis will improve the ischemia of both the LAD and the dependent RCA territory. So I hope you understand that concept. So in terms of numbers and study, I will provide this slide that summarizes everything for FFR. FFR less than 0.80 identifies ischemia with a very high specificity, as I mentioned. FFR over 0.80 is very important to know that this should rule out PCI. PCI should not be performed in a patient with a true FFR over 0.80, assuming there are no technical issues. And this has been shown in multiple studies, such as DEFER trial and, most importantly, FAME trial, in which patients were randomized to an angiographic guidance, regardless of FFR, versus FFR guidance for stenting, with deferral of stenting if FFR is over 0.8. FFR guidance improved the combined MACE compared to angiographic guidance. And that's what put FFR on the map, the FAME trial. Now, importantly, if you have FFR 0.8 or less, that doesn't mean you have to stent. It means you're allowed to stent. In fact, in order to qualify for stenting, you have to have a significant lesion, FFR less than 0.8, and severe exertional angina. As it has been shown in those several major trials, mainly ischemia trial indirectly and FAME2 trial directly, stenting of FFR of 0.8 or less compared to medical therapy does not improve hard outcomes such as death or MI at 3 and 5 years, but it does improve in FAME2 trial, it does improve angina and future need for revascularizations. So FFR 0.80, less than 0.80 plus severe exertional angina qualifies you for stenting. Importantly, FAME studies 1 and 2 and 3 recruited stable CAD. So FFR is mainly valuable to defer PCI in stable CAD. I will comment on the applications in MI later on. Some additional notes that you need to know in the FAME trial, in the FFR arms, stenosis that are 50 to 70%, 35% of those were significant by FFR. So most of the 50 to 70% stenosis were not hemodynamically significant. And even 20% of stenosis that are 70 to 90% were not hemodynamically significant. Just know those numbers whenever you see a lesion. Another important idea of the FFR is that, okay, I have a lesion with FFR 0.80. I'm not stenting it. That can make some people anxious. You have an 80% stenosis with FFR 0.82, you're not stenting it. However, a FAME trial, one of the very important findings is that deferral was very safe for a lesion with FFR over 0.80. In fact, the rate of MI occurring in a deferred lesion with FFR over 0.8 was only 0.2% at 2 years. However, don't be fooled by this number. Those patients have heavy and multiple atherosclerotic plaques. So the risk of MI in general is not minute. They have an intermediate risk of MI, including MI in that vessel where you did FFR. The risk of MI was still 2% at 8 months and 8% at 5 years in FAME2 trial. However, the MI from an individual lesion where you've measured FFR in that vessel and the FFR was 0.80, the MI from an individual lesion is very low. The summation MI risk is still relatively significant. However, you will not derive a benefit from stenting that particular lesion. On the other hand, if you have a lesion with an FFR less than 0.80 and you're not stenting it, the rate of MI is 2 to 3% per year. It's much higher than the rate of MI of a lesion with FFR over 0.80. So a lesion with FFR less than 0.80 has a much higher risk of MI on a relative term. However, in absolute terms, the risk of MI is still not very high. And that's one of the reasons in FAME2 stenting did not improve outcomes, because stenting by itself is associated with 2 to 3% combined risk of peri-procedure MI, stent restenosis, and stent thrombosis. Another idea that came from FAME trial is that FFR in multivessel disease has better spatial resolution than nuclear perfusion imaging, as perfusion imaging with SPECT in particular is a semi-quantitative assessment of flow difference between different territories. It's not an absolute flow measurement. So with nuclear imaging, you can have balanced ischemia that underestimates the extent of CAD. So FFR was significantly more sensitive than nuclear perfusion imaging in multivessel CAD. In fact, a nuclear sub-study of the same trial showed that 34%, remember that number, 34% of patients with ischemia by FFR had a negative nuclear scan. Now you can make up for a negative nuclear scan and find ischemia in those patients by listening to chest pain on exertion, EKG changes, TID, but the perfusion imaging was negative in 34% of patients with significant FFR and multivessel CAD. Now, I will move on to describe the IFR, that other very important index that is more commonly used today than FFR. It's the instantaneous wave-free diastolic ratio, IFR. So what's the concept? IFR uses the concept that microcoronary resistance is lowest and flow is highest in diastole. Therefore, in diastole, the PD to PA ratio at rest drops the most and approximates flow ratio, again, because flow is highest and microcirculatory resistance is lowest in diastole. So that pressure ratio at rest in diastole approximates flow ratio even without using adenosine. So this is a resting ratio, unlike FFR, which is a vasodilator ratio, hyperemic ratio. Okay, so this one is a resting ratio. So the cutoff of IFR significant is 0.89. It's not 0.80 because you are not inducing hyperemia. You're not going to get as high of a flow, and therefore the drop in that ratio, even in diastole where the flow is highest, is not going to be as pronounced as the drop in that pressure achieved when you do maximal hyperemia and you maximally increase that flow as when you give adenosine. So the cutoff is 0.89 rather than 0.80 with adenosine. Importantly, because you are not inducing hyperemia with IFR, IFR may underestimate the severity of stenosis in arteries with very large territory or very healthy microcirculation, because you have a potential for a very high increase of flow in those lesions with hyperemia, where you can induce a massive hyperemia, and where the PD can drop dramatically, much more during hyperemia than during resting diastole. That's why you can imagine that more lesions would be significant by FFR than by IFR, and that could be a concern. However, two large trials, FLAIR and IFR Sweetheart, have shown that IFR-guided PCI was associated with long-term outcomes similar to FFR-guided PCI, despite the fact that 25% less lesions were considered significant and stented by IFR. 29% of lesions were significant by IFR and stented versus 37% were significant and stented by FFR. But importantly, despite that, there was no difference in death MI and even no difference in the need for future revascularization for angina at 5 years. So you can apply IFR safely, and you're not hurting the patient by not stenting a lesion with negative IFR, but positive FFR, okay? So I will talk a little more here about IFR, FFR discrepancies, which is an interesting concept. Again, I described that clinically, even if they are discrepant, the patient will do well if you avoid stenting based on those two trials and some other studies that I will show. But I still want you to understand those concepts and discrepancy. Again, the main reason for the discrepancy is that you are inducing in some vessels with healthy microcirculation and large territory, you are inducing massive hyperemia that causes a dramatic drop in distal pressure with adenosine and dramatic drop in FFR, much more than you would get a drop in diastolic at rest, in diastolic pressure at rest. So IFR may underestimate the severity of arteries with very large territory or healthy microcirculation because the increase of flow in those lesions with hyperemia is massive, and FFR would drop far more than a resting ratio. Hence, more lesions are significant by FFR than IFR, but similar long-term outcomes. So if a lesion is significant by FFR, but insignificant by IFR, you're not hurting the patient by not stenting. And that discrepancy, FFR positive, IFR negative, was shown to be around 14% in a study called Figaro. It's more in some other trials, up to 20%. And it's more so in the case of RCA, definitely more so in the RCA than in the left coronary, 23% discrepancy, meaning IFR more frequently underestimates physiologic impairment in RCA than in the left coronary. Why is that? In the RCA, the flow is as dependent on systole as on diastole. Unlike the left coronary, where flow is predominantly diastolic flow, in the right coronary, flow is equally systolic and diastolic. And therefore, maximal coronary flow can occur during late systole or early diastole instead of mid diastole where IFR is measured, okay? Another situation where FFR and IFR could be discrepant are left main disease, and I will elaborate on that later on in this talk. But keep in mind that neither FAME nor IFR major study excluded left main, and most likely in left main, FFR and IFR are complementary, actually. You can have negative FFR with positive IFR in the left main, so they are complementary. Another situation where IFR may underestimate the severity, hemodynamic severity of stenosis is low resting flow state with very high flow reserve, such as a patient with slow pulse, patient on high beta blocker doses. He may have very low resting flow, but a very high propensity to increase that flow with hyperemia and with exercise, and he may have that discrepancy, okay? Now, I describe mainly the positive FFR, negative IFR, which is seen in 14 to 20% of patients, more so in RCA. Now, there's another discrepancy, negative FFR, positive IFR. It can happen in 6%, it's less common, but it is seen in patients with dysfunctional microvasculature and less propensity to have a hyperemic response with adenosine. So those are patients whose resting ratio, PDPA, doesn't change dramatically when you give adenosine. Why? Because they tend to have an unhealthy microvasculature. They are elderly, smokers, CKD, diabetics, patients with diffuse disease, as has been shown in that Figaro study. So in some 20+% discordance between IFR and FFR, it could be more commonly FFR positive, IFR negative, or FFR negative, IFR positive, less commonly. This is an important study that showed that if you defer a lesion with discrepancy between IFR and FFR, the long-term outcome is the same as when you're deferring a lesion with negative both IFR and FFR. So either one, when IFR is negative or when FFR is negative, and you're deferring the lesion, the patient will do well long-term, even if the other index is positive. So you really don't need to check both, except probably in left main, okay? So I want to describe other non-adenosine indices beside IFR. So IFR measures the PDPA ratio in a particular part of diastole, that is the wave-free portion of diastole, not throughout all diastole, throughout the period of diastole where you have no waveform and where you have the lowest resistant and highest flow. There's another ratio called DFR, where you're measuring the ratio throughout all of diastole. In reality, those two indices, IFR and DFR, are practically exactly the same. They correlate in more than 99% of the time. So really, there is no difference except for the manufacturer here. There is another interesting index I want you to know. It's called RFR by another manufacturer, Abbott. This RFR, basically what it does, it picks the point, whether in diastole or systole, where you have the highest PD to PA ratio. Okay, so in those patients, in a proportion of patients, the highest PDPA ratio may actually be in systole, in end systole, particularly in the case of RCA. RFR correlates strongly with IFR and with a cutoff of 0.89. It has less correlation in the case of RCA, where 32% of RFR highest PDPA gradient occurred in systole. So in institutions that have this, it may be a good index to use in RCA to compensate for the pitfalls of IFR in RCA and the importance of systolic flow in RCA. Another thing you need to know, IFR is meant to be a resting gradient. You should not measure IFR immediately after flushing contrast or saline. When you flush contrast or saline, the resting pressure ratio throughout the cardiac cycle, and specifically during diastole, will drop. So the 0.89 cutoff does not apply because it's becoming a hyperemic gradient. Now, if you want to measure the ratio during contrast, there is a value for that. A full cycle PD-PA ratio under contrast is a hyperemic kind of an FFR flow ratio, and the cutoff value for that is 0.83. And contrast FFR, and I will use the term FFR because it's hyperemic, and therefore pressure ratio correlates with the flow when you're inducing hyperemia, including with contrast. So, but the cutoff for contrast FFR is 0.83, and that strongly correlates with adenosine full cycle FFR of 0.80. So do not use contrast when you're doing IFR, and after you flush your contrast, make sure you wait at least 30 seconds to a minute before measuring your IFR and DFR. Otherwise, you'll get a falsely low value. It's very important. Okay. I will move on now to describe the technical aspect of how to measure FFR and IFR. So one is you use a 6 French guide to engage the coronary, but keep in mind that actually you can use a 5 French or 6 French diagnostic catheters. There are caveats to that. Evidently, if you create a complication with your wire and you have a diagnostic catheter, you're not going to be able to bail yourself out. You're not going to be able to intervene. And you can damp the aorta a little bit. But it can be done with a diagnostic catheter if your suspicion of a significant disease is very low. And if you don't want to re-engage the coronary in difficult engagement. It's very important to give nitroglycerin before you do your measurement. Why? Because adenosine is much more of a microcirculatory dilator than an epicardial dilator. It only has minor epicardial effect, whereas nitroglycerin is an epicardial dilator. So you need to give nitroglycerin to eliminate any potential epicardial vasospasm, including vasospasm from wiring itself. Okay? Second idea is that as you're advancing your wire, you have to equalize. The pressure sensor of that wire is at the back of the radio opaque portion. So as you're advancing, you have to equalize the pressures at the tip of the guide. You make sure that those two pressures are equal. PD and PA are equal at the very tip of the guide. And there are two key steps to do when you're equalizing. One, you have to remove that needle from the TUI burst device. That's one. And because otherwise, if you keep that needle, it will fakely drop the aortic pressure and it will create a fake equalization. Number two, you need to flush the catheter and remove the contrast to eliminate that aortic pressure damping. So after you do that equalization, then you advance your wire and you place it 2 to 3 centimeters distal to the lesion. You don't want to put it too distal. You want to make your measurement somewhat specific for that lesion. If you put it too distal, you'll get a summation of significance of all lesions of the vessel. You want to make it kind of close to the lesion, but not too close. 3 centimeters is a perfect area. And again, reflush the catheter from contrast before you do your measurement and wait at least 30 seconds after contrast if you're doing IFR. Now, for FFR, you can do hyperemia with intravenous adenosine. That's the gold standard, using a large IV access, ideally at least 18 gauge. You can use IC adenosine over 50 microgram for RCA or 100 microgram for left coronary. And, you know, there are, when you do the IC adenosine, keep in mind that it's very short acting. So you have to give it and flush it very quickly in saline and make your measurement within 10 seconds. Another important tip is that you need to disengage the guide during measurement, especially if the guide pressure is damped or ventricularized. And I will elaborate on that very, very important point. You can use a side hole guide as long as you disengage your guide during measurement. Another second important idea, after measuring a borderline FFR, you need to pull back that wire and make sure once more that you're properly equalized and that you did not have a pressure drift, transducer drift of that pressure wire, which is prone to drift, especially with the older generation of wires. Okay. So those two are very important, those last two, and they create error in FFR measurement in up to 30% of patients. So this is what I mean by equalization. When you put your pressure sensor at the tip of the guide, you have to make sure that the PD and PA are perfectly well superimposed. Neither one of them is damped. So those are the two important sources of error when you're measuring FFR and IFR, and that are alluded to by those 2 points. One is a pressure drift, and that's why you need to assess proper equalization at the end by pulling the wire back and verifying that PD and PA are still equal. Pressure drift tend to create a falsely positive FFR, meaning that it's the PD that tend to drift down, and that creates a falsely low FFR. Sometimes you can realize it, as I explained, by the fact that PD, which should be ventricularized, is no longer ventricularized. Okay, that's one idea. The second idea is extremely common and misunderstood is Ostial guide obstruction-Aortic waveform distortion, which can create a falsely negative FFR. So I'll elaborate on this. Imagine you're assessing this LAD stenosis in a patient with small left main, not an obstructive left main, but a small left main with moderate disease. You're not worried about it. However, when you put a guide and you wedge it in that left main, the guide is obstructive, okay? And this is when you get guide pressure ventricularization, because it's now seeing more the downstream ventricular pressure. So you may have a ventricularized, this is a guide ventricularization. You go from an aortic pressure to a ventricular pressure that is horizontal and diastole, sometimes with a wave. This is subtle ventricularization here, horizontal between peaks. So you get guide ventricularization. And if you measure the pressure distally and you give adenosine and you measure the PD to PA ratio, how would this compare to the true PD-PA ratio? What happens, the guide is creating an obstruction. Therefore, the guide is impairing flow across the stenosis. And as I explained, as you're reducing the flow across the stenosis, you're reducing the drop in pressure across the stenosis. Therefore, the PD to PA, whether it's IFR or particularly FFR, will be dramatically overestimated, meaning your FFR will look a lot better than in reality because you're creating an obstruction. So let's say with a guide in, your FFR is 0.85, you disengage that guide, your FFR becomes 0.70. Okay, again, because the guide is creating an obstruction to the flow. It's attenuating the flow, it's attenuating the drop in pressure, and it's attenuating the drop in flow you would see past the stenosis. This is happening with both IFR and FFR, but it's more pronounced with FFR because FFR relies on creating massive hyperemia. And that guide will create even further impairment of flow when you're trying to create hyperemia. Okay? So this is an illustration of that. The FFR would be 0.70 if your guide is disengaged, but it becomes 0.85 when your guide is engaged. And how do you understand this phenomena? Again, I explained earlier that your distal pressure should be ventricularized. Here I showed. Your distal pressure should be ventricularized when your FFR is significant. However, your aortic pressure should never be ventricularized. If your aortic pressure is ventricularized, you should, this is a hint for you that your guide is too deep and obstructive, and it's impairing FFR measurement. You need to disengage it and get the true FFR, which will be a lot lower than when your guide is engaged. Okay? So guide ventricularization at rest or with hyperemia is a hint to this phenomena. You're more likely to ventricularize the guide as well with hyperemia than with rest. Again, you create higher flow across the guide obstruction. You'll create more drop in diastolic pressure across the guide and more ventricularization across that guide pressure. That's why an observation for all interventionalists, when you give nitroglycerin in an obstructive guide, actually your guide ventricularization will become more pronounced because you create more flow, therefore more drop in pressure and more drop in flow across it. Okay, this happens with adenosine as well. So the guide needs to be disengaged in the aorta during FFR measurement until no longer ventricularized. Now, some doctors say that you should also disengage while you're doing equalization. I don't believe that's true. You don't need to disengage your guide during equalization because, meaning when your pressure sensor is here and you're equalizing aortic and coronary wire pressures. Because during equalization, you are just correcting for error of zeroing and leveling of the transducer, and you are ensuring that both pressures are equally leveled just inside the guide. Flow has no relevance to that. So, and what I explained here in terms of guide obstruction and causing a falsely high FFR, the same phenomena happen with side holes guide. You can use side hole guide and do the same as with regular guide, disengage during measurement. The issue is that, as my fellows know, one, I hate side hole guides. You should rarely use them for a variety of other reasons. And two, side hole makes it hard to recognize this phenomena because it attenuates the ventricularization while still causing ischemia and obstruction of flow. And that's one of the reasons I hate side hole guides in general. It makes you not recognize guide obstruction and left main ischemia. Importantly, one study has shown that even if you are not ventricularized, it's always good to disengage the guide during FFR measurement, as guide may be slightly obstructive. You get more flow and more FFR drop with disengagement. And this is here from that paper in 2015. So This is a case where your guide, that red pressure, was ventricularized, and you measured FFR with adenosine as 0.90. Now, when you disengage, your FFR went down dramatically to 0.79. Again, the same phenomena will happen had you been measuring IFR. It may be less pronounced than FFR because you're not creating hyperemia, but it will happen as well with IFR. So you always need to disengage that guide. This is another case, even more interesting from that paper, where the aortic pressure was not ventricularized. Yet when they disengaged, the FFR still dropped, not as much, but it dropped 0.03. And the mean delta FFR after disengagement was 0.05 plus or minus 0.04, although most patients in that paper did not have obvious ventricularization. So this is very important. And that disengagement, even if your guide is not ventricularized, is particularly important when your FFR is in that gray zone close to 0.80. You went from 0.82 to significant FFR just by disengaging, even without ventricularization. Now, here is an important technical idea. There is a reason a lot of doctors don't like to disengage the guide, and they stick with wrong measurements of FFR and IFR, because we live in a radial era. Imagine how hard it is to disengage. When you disengage in a radial catheter, especially a radial guide, sometimes that guide will fly all the way out in the ascending aorta or subclavian if the patient takes a deep breath on top of it. And you may lose everything, including your FFR wire, and you have to restart over. So how to compensate for that? And that's an extremely important slide for interventionalists, how to measure FFR with disengaging the guide. It is best actually to double wire the coronary. And there was one major circulation paper that recommended that as best practice for FFR and IFR measurement. So put another wire. This way you will have in that coronary 0.028 inches of wire. So when you disengage the guide, it's less likely to fly out. It's held tight by a heavier body of wires. And you can put the wire anywhere. You can put it in another artery, or in that paper, they recommend actually wiring before putting the FFR wire, wiring the lesion itself with a regular wire, then putting the FFR wire. This way, actually, the wire that's placed distally in the lesion, it has several advantages. One, it anchors the guide, but also it allows you to do an FFR pullback without having to worry about losing wire position distally. And also, it gives you guidance when you're wiring with FFR wire, so you have to use less contrast and less need to flush and less error in measurements. Okay, so very important. You have to double wire oftentimes if you need to disengage the guide. This is from a case I did recently. This is a CLS guide. It's hard to disengage those CLS guide because it's a little hard to engage them. So it's, I did FFR of the LED, but I had put a wire in the left circumflex, which allowed me to safely disengage the guide. I disengaged even though there was no ventricularization of the guide pressure. So along those same lines of ostial obstruction, how about the patient I was describing, assessing a distal lesion through a moderate ostial disease and ventricularization? How about if you have significant, or if you want to assess a more significant ostial disease? Here also, clearly you need to disengage. The guide, again, is preventing hyperemia and is making your FFR and IFR look better. Another reason to make your IFR, FFR falsely high is that if the guide catheter is too deeply engaged, the PA at the tip corresponds not to the aortic pressure, it corresponds to the lesion pressure, to the PD, which is the pressure past that particular lesion you're assessing here. So the PD-PA ratio will be approximate to each other, and therefore they will be much higher than truly. So they will be falsely increased. So this is from a case referred to me from an outside hospital. The patient has an ostial left main stenosis, and they measured it by IVUS to be 4.5, less than 6, significant. But the IFR was 0.91. So I, immediately recognized what the error was, even before, even without looking at the tracings they had. I recognized that they probably did not disengage the guide. And I did the same thing myself to prove it. So I did this case and I did the IFR while the guide was while the guide was engaged, partially engaged, not fully engaged, partially engaged in that left main. The IFR was 0.90, but notice that the aortic pressure was ventricularized, which is always a no in those measurements. So I disengaged and the IFR went down dramatically from 0.90 to 0.71. You cannot underestimate how important it is to disengage a ventricularized guide. And this was, missed sometimes by experienced people. Okay. And again, the distal pressure is ventricularized, but the aortic pressure should never be. Okay. I hope this was clear because I want to move to another pitfall. So I described two major pitfalls, very common one, transducer drift, which occurs in up to 20% of patients in that circulation paper from 2019, and the Ostial guide ventricularization and distortion, which occurs in up to 10% of patients, very common. There is a third technical pitfall, more controversial. It's an idea not much talked about, which is that frequently in 20 to 30% of patients at the onset of hyperemia, and this idea applies for FFR, not for IFR. So at the onset of hyperemia, when you give adenosine, you get an initial nadir of FFR, which is followed by a higher steady state plateau of hyperemia. Okay, so big nadir initially, you get more dramatic drop in that FFR value, then the FFR rises by a few points and stays more stable there. This is due to the fact that coronary microcirculation dilates before systemic circulation. So PD may drop before PA and cause a falsely lower initial value of FFR. We should probably take the steady state, not the early nadir value, as it has been suggested in those two studies. And unlike what the software takes the lowest value. I disagree with that. I like to take, as in those two papers, the steady state value, okay? And in that steady state, it's not a full steady state. You get bump and sometimes pronounced bumps. But in the steady states, after the first 15 to 30 seconds of drop, I take the lowest value. So I take the lowest value of those bumps, but not the lowest value during that initial nadir 15, 30 seconds. Okay, so that's an important idea. And, this is in accordance with the definition of FFR used in major clinical trials, such as the FAME trials. They say, without explaining in details, wait for stable hyperemia and use a stable value as FFR. This is particularly important in borderline FFR. You have an FFR of 0.82. It might dip initially to 0.78. What should you take, 0.78 or 0.82? The computer takes 0.78, but I take 0.82 based on this and based on my review of how FFR has been defined historically. Okay. Another idea is if you have ectopic beats. Ectopic beats, it's fine with FFR, but I would still take the lowest value beyond the nadir with FFR. However, with IFR, I would not take the post-PVC IFR. The idea is that after a PVC, you get an increase in flow. And this, whereas IFR, again, is a measurement at rest. So post-PVC is no longer rest. Therefore, the IFR post-PVC is not a true resting IFR. It may be lower than at resting state. So I try to avoid using IFR post-PVC because I don't believe it's a resting ratio anymore. So after describing all this, I hope that was clear because I want to move on to other topics of interest that are also very important practically. This one is important and kind of complex. It's the serial stenosis complex with FFR, which is a very common problem. So you have serial stenosis in a lesion, lesion 1 and lesion 2. It's problematic with FFR particularly and somewhat with IFR. The idea here is that if you calculate the local, what we call local FFR, although those are not true FFR, local pressure ratio under adenosine, P1 to PA and P2 to P1 ratio, those will underestimate the true FFR of each lesion. Why? Because had there not been another lesion, the local flow across each lesion will be higher, and the pressure drop across each lesion will be higher. Again, it's about flow. Having another lesion impairs the flow across the first lesion, therefore impairs the pressure drop and the measurement that you're achieving with IFR and particularly with FFR. In fact, for example, the presence of lesion 2 prevent maximal hyperemia past lesion 1. And therefore, that P1 is not a correlate of peak flow past lesion 1. And therefore, P1 to PA is not an FFR, is not a flow ratio anymore, because there is no maximal hyperemia in this segment. You're not dilating the microcirculation maximally in this area because most of the microcirculation is distal. Okay, so P1 to PA is no longer an FFR ratio, and it's much higher than the true FFR of this lesion. Same also with P2 divided by PA. It's higher than the true FFR of this lesion. However, P2, which is a summation of pressure drop across both stenoses, is still an adequate estimate of the flow drop from all those stenoses across all those lesions. So P2 is still a correlate of the distal myocardial flow under maximal hyperemia. However, the local pressure drops do not correspond to local FFR, and they do underestimate the severity of each lesion. So how do you do practically? How do you do those studies practically? And I will explain it here. But before that, I want to explain that the interference between lesion 1 and lesion 2 is more profound if the distance between 1 and 2 is short. Conversely, if the distance is long, meaning if you have a proximal LAD stenosis and very distal apical LAD stenosis, well, you're still achieving hyperemia in that segment P1 here, because you do have a large territory and a lot of microcirculation. You're still achieving hyperemia, and therefore P1 to PA is still a proper FFR and approximate the FFR you will get after fixing lesion 2. So the longer the distance, the more it's okay to measure local FFR as P1 divided by PA without fixing the other lesion, okay, without interference from the other lesion. Also, the more severe any of the stenosis and the more severe the summation FFR at the end here at P2 level, the more that you will have interference in those lesions. Evidently, the more severe any of stenosis and the more severe the summation FFR, the more you have impaired flow, and it's all about flow. Everything we described is the effect of flow on pressure. So the more you have impaired flow, the more your flow ratio or pressure ratio will be impaired. For the same stenosis severity, that's an important point I will mention here. For the same stenosis severity, the distal lesion affect the proximal lesion much more than a proximal affect distal. So if you have 70% proximal LAD and 70% mid LAD, that mid LAD will cause you to underestimate the proximal LAD more than the proximal will make you to underestimate the mid LAD. And I will explain it why. The problem is that, why is that? When you have serial stenosis, P2 still dramatically drops with hyperemia, but P1 does not drop as much. There is no much hyperemia at P1 level. So even if the proximal stenosis is more hemodynamically significant, P1 is not going to drop much because there is no hyperemia at this level. So you may see more pressure drop at P2, much more at P2 than you would see at P1. And therefore, that local P2-P1 ratio will be much lower than the P1-PA ratio in patient with serial stenosis. Okay, so the distal affect the proximal more than proximal affect distal, particularly with adenosine. So this is how we do the study. Practically, you get a summation FFR, which, as I said, P2 is still an appropriate correlate of the distal myocardial flow and the distal and the impairment of flow and pressure from the summation of all lesions. So we put the pressure distally, we get the summation FFR, in this case, for example, 0.50. Then you do pullback and you look for stair-step pressure drops during pullback. Okay. And what you do, okay, we have two lesions, more pronounced drop here, less pronounced drop here. Those are two stair steps. And what you do, you fix the lesion with the most stair step, which is lesion 2 in this case, and you reassess your FFR. It's possible if you fix lesion 2, it's actually probable after you fix lesion 2 that lesion 1 pressure drop, which is the true FFR of that lesion 1, will drop more. It may drop dramatically. It may even drop to a level almost equal to the initial drop. So you fix that lesion 2 and your FFR eventually doesn't change. The drop across lesion 1 causes you to have the same FFR. So it's unpredictable to some degree. But anyway, that's how you do it. You fix the lesion 2, then you reassess FFR across lesion 1, and you fix it is needed, or vice versa. If 1 was the most significant, you fix 1, then you fix 2 if needed. Okay. Now, because this phenomena is very much exaggerated by hyperemia and by hyperemic parameter, and that's why it may be better to use a static, not hyperemic parameter like IFR, and I will explain why is that. IFR is not as dependent on a dramatic rise of flow, unlike FFR, and therefore IFR may not have as much crosstalk between lesions. So serial stenosis crosstalk is exaggerated by hyperemia, high flow. The higher the flow, the higher you want, the more you will have a pressure drop across each lesion had you not had the other one. And therefore, the more you underestimate it by the presence of the other lesion. So serial stenosis crosstalk is exaggerated by hyperemia and high flow. It may be better to use static non-hyperemic parameters like IFR to assess which lesion is more important. So when you fix and basically use local IFR pullbacks with local IFR. When you fix one lesion, flow rises and IFR drops, but not as much as if you had given adenosine and caused a dramatic rise in flow. Therefore, the local IFR drop at baseline is closer to the IFR you will get after fixing the other lesion, again, because you're not inducing hyperemia. Another idea is that without hyperemia, the drop in and hyperemia, which is affecting that microcirculation here, and it's affecting P2, not affecting much of P1. So without hyperemia, which dramatically affects P2 more than P1, P2 drop may not be exaggerated compared to P1 drop. And therefore, the local IFR2 may not be exaggerated compared to IFR1. So less crosstalk and less effect of the distal lesion on the proximal lesion. Yet, even if you have one stenosis that is very severe, more than 90%, the crosstalk is likely to remain pronounced across the other lesion, even with IFR. But nowadays, the recommendation with serial stenosis is to definitely use IFR, not FFR. And this is the paper that put that on the map. It established that IFR at baseline with the presence of the two stenosis correlates very much with IFR after you fix one of the stenosis. It's not much different. And this is an illustration from that paper. They use what we call IFR coregistration with the angiogram. Basically, you place your IFR wire distally, then you start IFR recording and you do pullback under fluoroscopy, then you do a cine image. And the software from Philips, IFR coregistration, will allow for an overlay of the IFR values on the angiogram. And it will show you the site of the most drop. So in this case, the site of the most drop was here. Okay, they dropped 0.09. The total IFR was 0.85 distally, and they dropped 0.09 here. So they stented that, and the IFR, they expected the IFR to rise almost linearly by 0.09, and it rose 0.07, so very close to linearly. And that's what they showed in that paper. The IFR drop almost linearly correlates with how much the IFR will rise after stenting, unlike the unpredictability of local FFR. If you had an FFR of, distal FFR of 0.70, and you fix a proximal lesion, it's unpredictable how much the FFR will rise. It's, you cannot use the FFR drop of, let's say you drop FFR by 0.10 across a lesion. It doesn't mean it's going to rise. The distal FFR is going to rise by 0.10 after you fix that proximal lesion. It may not rise at all. It's very unpredictable. So use IFR. It's been shown to correlate almost linearly with how much the true FFR will be after stenting the other lesion. Okay. This is another case from another paper, but anyway, the IFR was 0.41 with a drop of 0.51 here. After they stented this, the IFR rose almost as predicted. It was predicted to be 0.92, it rose to 0.88. So almost linear correlation. This is from a case I did yesterday. So the patient has severe mid-LAD stenosis, but I was worried he also has a lot of proximal to mid stenosis here. Should I just fix this, or should I stent the whole thing, as a lot of interventionists would do? So I did IFR pullback. IFR was 0.7877 distally, and we had 0.14 drop here. So I stented that, and the IFR went up to 0.90. So I was fine. It was, again, almost linear correlation with your eventual IFR after you fix the lesion of interest. So I had 0.14 drop here, and after I stented, the total FFR rose by 0.12. So almost linear correlation. So it correlated with the fact that those local IFR drops here were not significant and remained insignificant after I stented the distal lesion. Okay. Those were difficult concepts, but I hope you understand them. Along those same lines, I will talk about diffuse disease. So if you have an FFR less than 0.80 or IFR distally less than 0.89, but the pressure pullbacks reveals a gradual decline in pressure without that stair-step focal drops, the patient may not be served by PCI. You should not stent him. You'll have to stent the whole vessel. There is no focal drop. There is no focal area with a dramatic rise in IFR or FFR on pullback. However, this patient may be served by CABG, which provides diffuse forcing of flow throughout the whole vessel. And this is an important concept because this may be seen in patients with mild or moderate diffuse disease and small coronary artery. In fact, if you do FFR on all patients with diffuse moderate disease, 8 to 10% of arteries will have significant FFR less than 0.75, which explain myocardial ischemia and angina without angiographically obstructive disease over 50%. This is an example of such case. You have a progressive, this is a significant FFR, but this was a progressive drop in pressure, no particular area that you can stent unless you stent the whole thing, which is not advised, but bypass could be used. This is another case with IFR. Again, you see here progressive, no significant pronounced focal drop. I would like to continue with this talk and provide for about 15 minutes for those who can stay, a description of an illustration of those FFR and IFR use in other important settings. So I will keep going here. And first, I will describe the application in left main disease. So in left main, several prospective studies have shown that deferral of coronary bypass grafting based on FFR over 0.8 is associated with very good long-term outcome, similar to the outcomes of patients with left main FFR less than 0.8 who receive CABG. So those are multiple FFR studies. Okay. There are also similar IFR studies that I will mention as well. But both FFR and IFR have pitfalls. And this is the reason for that. You know, the problem left main is rarely an isolated disease. Most commonly, you have LAD and or left circumflex disease. And therefore, what you have, you'll have the serial stenosis problem. So if you have an LAD stenosis, you have lesion 2 and lesion 1, you're not going to have, you'll be impairing flow across that left main, and therefore you'll be impairing the pressure drop across that left main, whether at rest or particularly with hyperemia, you'll be impairing the pressure drop across that left main. Okay, so some people say, okay, if I have a proximal LAD disease, okay, well, let me put that wire in the circumflex to obtain a standalone assessment of the left main. This is totally incorrect. I really want you to understand that. That LAD stenosis is impairing flow across that whole left main carrefour wherever you put your wire at, okay? The maximum flow across the left main is impaired by that LAD stenosis. So it doesn't matter where you put your wire, that whole carrefour area flow is impaired by the LAD stenosis, whether you put your wire here or you put it there. Okay, so you will get the same value of FFR or IFR, whether you put your pressure sensor here or whether you put it there. So please don't think that putting it in the normal branch vessel will attenuate the effect of that LAD stenosis on the left main. Okay, so what do you do here? What you can do is place the wire distally to the severe stenosis and get summation FFR. If the summation FFR is significant and the second stenosis in the proximal LAD, you can consider CABG. But most often that scenario is, is not applicable. So another way of doing it, and one study has shown that if the composite FFR of the left main plus the downstream LAD or left circumflex disease is over 0.65, meaning if the composite FFR is not too severe, the isolated left main FFR that you're trying to estimate from putting the pressure sensor here is adequately approximated. The left main FFR is adequately approximated by placing the pressure sensor between the left main and the downstream stenosis, okay? Meaning if you fix that LAD stenosis and you remeasure the FFR, it's not going to be dramatically different from the FFR you're getting right now between those two, okay? And another idea is that the more distal your LAD or circumflex disease, the more accurate your left main assessment in between those lesions. So if you have a rather distal, mid to distal LAD or left circumflex disease, or if your summation FFR past that all disease is over 65, your isolated left main assessment in between those lesions past that carrefour is an accurate representation of the true FFR of the left main, okay? That's one idea you can use, and it's applicable to both FFR and IFR, okay? Now, how about using IFR? Because as I mentioned, IFR is advantageous in serial stenosis, and in theory, IFR may be more advantageous in left main disease where you have most often serial and branch vessel disease. So several registries have shown that IFR is applicable for left main, and deferral of left main revascularization based on IFR was associated with similar long-term outcome to patients with significant IFR who get revascularized. And another registry has shown that IFR of 0.89 has a strong correlation with IVUS MLA less than 6 millimeters square, even in patients with ostial LAD or ostial left circumflex. This was an important study published recently, that third one, iLitro, among patients with intermediate left main stenosis. The concordance, and what they did in that study, they measured IFR, FFR, and IVUS in left main disease. And what they found is that in intermediate left main stenosis, there is a good concordance between FFR and IFR of 80%. If they were discordant, they insisted on definitely measuring IVUS, although they measured it in the majority of patients. And if FFR and IFR were discordant, IVUS was most often significant. So any one of them, so you can do probably in left main, both FFR and IFR. If any one of them is significant, you should revascularize that left main, as most of them were significant by IVUS, okay? And there was good long-term outcome in deferred patients. Interestingly, in that paper, what you can see is that 22% of patients with IVUS of the left main less than 6 millimeters square had normal FFR and IFR. So 22% had normal FFR and IFR despite IVUS less than 6 millimeters square. And those patients by protocol in that study did well by not revascularizing the left main, even with that low MLA. That shows you the importance of hemodynamics if properly done, taking into account all the pitfalls. Conversely, even in patients with high MLA over 6 millimeters square, you had about 13% of patients with positive both FFR and IFR. This shows you how difficult it is to assess the left main. And this is my take on all of this. It's best to use both IFR and FFR in left main disease and combine it with IVUS if FFR and IFR values are discordant or if you have borderline value. And certainly if you have concomitant severe proximal LAD disease, especially if the summation FFR is less than 0.65. If the disease is more distal, or if the summation FFR is more than 0.65, I think you do very well by just measuring IFR and FFR. Okay. And per ilitro revascularize if 2 of the 3 are significant, and maybe 1 of the 3 is significant, IFR, FFR, or IVUS. So none of them is stone cold. Even 6 millimeters square is not stone cold. One of the reasons of 6 millimeters square may not be always applicable is that you have large patient where 6 millimeters square may be too low, maybe 7 millimeters square, 7.5 is the proper cutoff. And you may have a small patient where maybe 5 or 4.5 could be appropriate cutoff. Still use 6, but keep in mind that even IVUS has limitation as well. But it's handy when you have concomitant proximal LED or circ disease, especially severe proximal disease. I'll describe some other ideas. Can FFR-iFR be used in non-STEMI and in STEMI non-culprit? So really the main data for FFR and IFR is a stable CAD, not MI. The FAME trials excluded MI. So in non-STEMI, the question is not only whether the lesion is functionally significant, but whether the lesion is anatomically significant and likely to acute progress. Plaque rupture, thrombus. So IVUS OCT makes more sense in MI. And you would tend to stent a lesion with unstable feature and with some degree of stenosis. You don't want to stent a lesion with plaque rupture, but less than 50% anatomical obstruction. So you need the combination. But IVUS OCT makes more sense in that case. However, there is data for FFR in non-STEMI. And it's only FFR that was used. Famous non-STEMI trial and a large prospective European registry, so 2 sets of important data, have shown that in the setting of MI, PCI may be safely deferred for lesion with insignificant FFR 0.80. Basically, they had similar outcomes in the FFR-guided R versus angiography-guided R with less need for stenting under FFR guidance. Along those same lines, and probably better proven, is what to do with the STEMI non-culprit stenosis. So setting of MI, but non-culprit stenosis. 2 studies have shown that FFR-guided strategy is at least as good as an angiography-guided strategy in STEMI non-culprit stenosis. One is a frame MI, another is flower MI. The frame MI was presented recently at ESC, and it showed actually that FFR-guided PCI versus angiography-guided PCI of non-culprit stenosis actually improved both long-term mortality and MI. That wasn't the case in flower MI, but both strategies were equally good, with less stent in the FFR-guided. So the bottom line, yes, FFR can be used in non-STEMI and in STEMI non-culprit, although the data is not as good as in stable CAD. Those data were with FFR. IFR could theoretically be used, and maybe theoretically better, as it is not dependent on flow increase in patients with acutely dysfunctional microvasculature and maybe some impairment in hyperemic response. But IFR remains to be proven. Another idea I very much like, another topic, is aortic stenosis. So you have a patient, you're assessing a patient with aortic stenosis before TAVR or surgical AVR. You're doing coronary angiogram, and you find a moderate lesion. You want to assess if it is significant. So this study took such patient who were going to undergo TAVR, and they measured FFR and IFR before TAVR of that same lesion, and FFR and IFR after TAVR of that same lesion that they didn't fix. And they found that in terms of FFR, before the FFR before versus after TAVR, it drops dramatically. So your FFR goes from a certain value to almost 7-8 points lower after you do TAVR. Conversely, IFR does not change much after TAVR, and therefore the FFR value you get before fixing the aortic valve does not really represent the true functional significance of that stenosis, whereas the IFR value you get before fixing the valve better represents the functional significance of that lesion. Okay, and why is that? In aortic stenosis, the aortic valve acts like a stenosis to the coronary flow, not just to the aortic flow, but to the coronary flow. It's a flow-limiting stenosis to the coronary flow. So FFR before fixing AS is likely to underestimate FFR severity based on the serial stenosis concept. On the other hand, because IFR is less dependent on a dramatic flow rise, it's less affected in AS and is likely more reliable as it is in the serial stenosis concept. So aortic stenosis, use IFR, not FFR. This is beside the fact that adenosine may be unsafe in aortic stenosis anyway. So this is a summary of cases where IFR may be advantageous: serial disease, aortic stenosis, microvascular dysfunction. Those are cases where you cannot achieve hyperemia. So IFR is maybe more advantageous than FFR. And actually maybe IFR may be abnormal while FFR may be normal above 8.80. Now, FFR is advantageous when you can achieve massive hyperemia in a large territory. Example, left main, proximal LAD, young patient with focal disease and healthy microcirculation, and possibly in RCA. It may be less advantageous in elderly patient with diffuse disease, diabetes, CKD, as I described from the Figaro study, and unhealthy microcirculation, because those come together, that diffuse disease, CKD, diabetes, and microvascular impairment. It's also, FFR is advantageous, as I described in the RCA, where the systolic flow and the systolic drop in flow is important. So FFR and IFR, as I described, are complementary in left main and probably complementary with IVUS. One of the before final idea is post-stenting IFR. It's not as validated as post-stenting IVUS, and if you want to do something further assessment of the adequacy of your stenting, it's best to use imaging. That's more established. However, post-stenting FFR has value, and a lot of data suggests that post-stenting FFR over 0.80 or IFR over 0.89, and some use higher cutoff for IFR, are associated with good outcomes versus much worse outcomes if those values are lower than those cutoffs. So what do you do in those cases? So you can do post-stenting FFR, and if your FFR is less than 0.90, what do you do with it? Unlike IVUS, you're not getting an exact delineation of where the issue is, but you can actually get an exact delineation by FFR if you do it properly. So do pullback FFR or IFR and identify the problem, looking for either local FFR drops more than 0.05 or local IFR drops more than 0.03. And those are numbers to remember. Those were the numbers used in those in the two studies that assessed post-stenting FFR and IFR. And if you do that, you'll find that in patients with FFR less than 0.90, the stent under expansion is one reason you get a drop in FFR or IFR across the stent. You can have residual focal stenosis proximal or distal to the stented area, or edge disease and dissections, or you can have residual diffuse disease, residual drop in pressure without focal drop. In that case, you cannot do anything. But for those first three, you can do things, further expand the stent or add more stents in cases of 2 and 3. And there is this study target trial that randomized patient to post-stenting FFR. And one important idea is that 29% of the patient in that trial had FFR less than 0.80 after stenting. And post-PCI FFR guidance with pullback reduced the number of patients with FFR less than 0.80, and also reduced the percent of patients with FFR less than 0.90, which is the best cutoff. Okay. So of course, you want your FFR to be over 0.90, but at the very least over 0.80 after stenting. Similar findings were found in another study with IFR called Defined PCI. Also in that study, 24% of patients had an IFR less than 0.89 after stenting. And good proportion of those are due to diffuse disease, but the majority are not diffuse disease. The majority are processes that you can fix. And you can identify those by doing a pullback and seeking focal drops. So you can have good spatial resolution with FFR or IFR post-stenting. The last idea here, and I disagree with some interventionist about this concept here, so I do want to describe this idea. Should we do FFR-guided CABG? Meaning, should we only graft vessels with significant FFR? Here is the idea. I'm not saying whether we should use FFR to guide whether we need CABG or not. Yes, absolutely. If you have a patient with borderline left main and LAD and you want to decide whether he needs CABG or not, yes, do FFR and decide whether those lesions are significant. But the idea now is, after you've decided the patient needs CABG based on severe LAD and left main disease and multivessel disease, should you use FFR to fine-tune whether he needs a vein graft to the OM, whether he needs a vein graft to the PDA? And the idea here is, okay, if that OM has a significant FFR, I graft it. If that OM has a 70% stenosis, but the FFR is not significant, I don't put a graft on it. I bypass the patient, but I don't put a graft specifically on that OM. So several registries, and I want to now explain that I don't believe that should be done. Several registries have shown that FFR-guided grafting, meaning putting grafts only to significant FFR vessels, reduces graft failure from 21% to 9% at 1 year. And that led some interventions to argue, oh, okay, well, we should use FFR before bypass and graft only the ones that are significant to keep the graft from failing. However, this is not large. Still, at 1 year, you have to look at the other side of the equation. 80% of bypasses hooked to non-significant FFR were still patent. 80% were still patent. And another idea here is that putting less grafts by using FFR did not translate into improvement of clinical outcomes in the Fargo trial, which is the most important trial in that field. If someone argues about you about this point, tell him Fargo trial. So putting less graft based on FFR guidance did not improve clinical outcomes in Fargo trial. Worse, in Fargo trial, graft, the disease progressed quickly after CABG in those non-bypass vessels. Within 6 months, vessels with insignificant FFR, 40% of those vessels progressed to significant FFR. And the mean FFR of those insignificant vessels progressed from 0.89 to 0.81 6 months after CABG. So not only that, basically you've hurt the patient because 6 months later, that vessel that was not significant is now significant and you have not grafted it. So here's the bottom line. And why did this happen? In a patient who already needs CABG, unlike in the famed trials where we focus on stenting, in a patient who already needs CABG, the plaque burden is heavy. So one, the disease progression may be more aggressive, even if the FFR is insignificant. Two, CABG provides a benefit beyond reducing ischemia. That's why we do CABG, not just to reduce ischemia. Adding a graft to a moderately obstructed territory may still protect it from infarct, even if FFR is insignificant. Also, the difference in graft patency, even if real, it wasn't real in Fargo, but it was real in other registries. Even if real, it's not large. It's 80% versus 90%. Okay. So I will stop here. I will just show those slides. You can read them at your own convenience. Those are causes of falsely high FFR and IFR, causes of FFR truly more than 0.8 despite severe angiographic stenosis, and causes of FFR that is less than 0.8 despite the lack of severe angiographic disease. All right.